Hi and welcome to this module, where we will be discussing bradyarrhythmias and conduction blocks. Let's get started. The learning outcomes for this module will be as follows: atrioventricular block or AV block, trifascicular block, and long QT syndromes. An atrioventricular block or AV block describes a slowdown of signal conduction or a complete drop in the electrical impulse as it passes from the atria to the ventricles through the AV node. A first-degree heart block describes a prolonged PR interval on ECG. The sinoatrial node produces a regular electrical impulse that travels through the atria and into the atrioventricular node where it stalls. A PR interval greater than 0.2 seconds is diagnostic for a first-degree AV block. A narrow QRS complex implies the block is in the AV node, while a wide QRS complex implies the block is in the His-Purkinje fibers. A first-degree AV block is usually asymptomatic and is diagnosed on ECG. It can progress into a second or third-degree AV block and requires regular monitoring. There are two classes of second-degree AV block: Mobitz type 1, also called Wenckebach, and Mobitz type 2. Mobitz type 1 second-degree AV block is an irregular rhythm because the PR interval progressively lengthens until a QRX complex is dropped, similar to a type 1 second-degree SA block. The defect is at the AV node and is usually the result of excess parasympathetic tone on the AV node. Mobitz type 1 is often asymptomatic, does not progress, and does not require periodic monitoring. In a Mobitz type 2 second-degree AV block, the impulse from the SA node is periodically dropped at the AV node, resulting in a normal P wave followed by a drop of the QRS complex and T wave. The rhythm on either side of the drop is normal. Sometimes this drop forms a pattern. A 3-to-1 block describes a rhythm where only every third P wave is followed by a QRS complex and T wave. Mobitz 2 second-degree AV block can progress into a third-degree block and requires careful monitoring and usually a pacemaker. In a third-degree AV block, also called complete heart block, no impulse passes the AV node, and the atrium and ventricles follow their own pacemakers. The atria will follow the impulses produced by the SA node, and the ventricles will follow the ectopic pacing of the bundles of His at 30 to 40 beats per minute. Heart contractions become uncoordinated and pump little blood. Third-degree blocks are very dangerous. Symptoms include syncopal attacks, such as the Mogagni-Adams-Stokes attacks. A cardiogenic shock might occur, requiring immediate emergency treatment, which is administration of atropine or catecholamines. A pacemaker is a preferred treatment as soon as the patient is stable. When determining treatment, it is important to differentiate reversible conditions from irreversible conditions. Reversible conditions do not require a permanent pacemaker. They include increased vagal tone, infections such as myocarditis and endocarditis, electrolyte imbalance such as hyperkalemia or hypermagnesemia, medications such as beta blockers, calcium channel blockers, and mild ischemic events. Permanent causes of AV block require a permanent pacemaker. These include degenerative changes, fibrotic changes as seen in sarcoidosis and hemochromatosis, and surgery. Trifascicular block. Trifascicular block can be divided into two, a complete and incomplete trifascicular block. The combination of first-degree AV block with a left bundle branch block, a right bundle branch block with axis deviation, or alternating left bundle branch block and right bundle branch block is diagnostic for incomplete trifascicular block. If associated with syncope, trifascicular block represents an indication for pacing on both prognostic and symptomatic grounds. Didi is drinking water. Resume. If associated with syncope, trifascicular block represents an indication for pacing on both prognostic and symptomatic grounds. Pacemakers are electronic devices that stimulate the heart with electrical impulses to maintain or restore a normal heartbeat. The most common indications for permanent pacemaker implantation are sinus node dysfunction and high-grade AV block. Listed are amongst the other indications for pacemaker implantation. Indications are divided into different classes considering the benefits versus the risk of pacemaker implantations. Long QT syndromes. Long QT syndrome is typically characterized by a prolongation of the QT interval on the ECG and by the occurrence of syncope or cardiac arrest, mainly precipitated by emotional or physical stress. Causes of prolonged QT can be divided into inherited or congenital and acquired causes. Congenital causes include Romano-Ward syndrome, Jervell and Lange-Nielsen syndrome. Acquired causes of prolonged QT interval include drugs such as antiarrhythmic agents like amiodarone, antidepressants like tricyclic antidepressants and SSRIs, antiemetics like metoclopramide and ondansetron, antipsychotics like haloperidol, and antimalarial drugs like quinidine. Myocardial diseases such as myocardial infarction, third-degree heart block, and cardiomyopathies also can lead to prolonged QT interval. Another common yet reversible cause of prolonged QT interval is electrolyte imbalance, specifically hypokalemia, hypomagnesemia, and hypocalcemia. Long QT syndromes can be serious as patients experience syncope, sometimes with or without seizures. However, the more fearing presentation is sudden cardiac death. A family history of cardiac arrest and sudden death, especially at a young age, should be elicited, and this may indicate congenital form of long QT syndrome. What are the treatment for long QT syndromes? Beta blockers are effective in preventing cardiac events in a large percentage of patients with long QT syndrome, whereas cardiac events continue to occur despite beta blocker therapy in the remaining group. Propranolol is the most frequently used beta blocker, although atenolol and metoprolol are also prescribed in patients with long QT syndrome. The implantable cardioverter defibrillator has been shown to be highly effective in preventing sudden cardiac death in high-risk patients. The usefulness of implanted cardiac pacemakers is based on the premise that pacing eliminates arrhythmogenic bradycardia, decreases heart rate irregularities, thereby diminishing the risk of torsade de pointes ventricular tachycardia. Pacemakers are particularly helpful in patients with documented pause bradycardia-induced torsade de pointes and in patients with long QT3. In summary, bradyarrhythmias are common clinical findings and comprise a number of rhythm disorders including sinus node dysfunction and atrioventricular conduction disturbances. Clinical presentation varies from asymptomatic electrocardiogram findings to a wide range of symptoms such as heart failure symptoms, near syncope or syncope, central nervous system symptoms, or non-specific symptoms such as dizziness or fatigue. If reversible extrinsic causes of bradyarrhythmias such as drugs or underlying treatable diseases are ruled out, cardiac pacing is usually the therapy of choice in symptomatic bradyarrhythmias. We have come to the end of this module. Thank you.